Good morning, everyone. My name is Helen Mayer. I am a registered nurse from the ALS Association, and I cover the Hudson Valley. And I'd like to welcome you this morning to our first session of the day. And the title is New York Medical Aid in Dying, Smart, Compassionate Policies. And I'd like to welcome Corinne Carey. Before I actually do your introduction, Corinne, I would just like to tell everyone that after this session, we are able to have some question and answers, and there's a question and answer box that you can just add them as the morning goes on. So first of all, Corinne Carey is a lawyer. She's a public policy analyst and an organizer. She's a senior campaign director in New York and New Jersey for the national nonprofit organization Compassion and Choices. She has successfully led the effort to authorize medical aid in dying in New York, which adopted the legislation in 2019 and led the campaign to pass New York's Medical Aid in Dying Act since 2015. So Corinne, thank you so much and welcome, and whenever you're ready.
Can you hear me now? It just asked me to unmute. Okay. Well, hopefully I was unmuted this whole time, but Compassion and Choices envisions a society that affirms life and accepts the inevitability of death, embraces expanded options for compassionate dying, and empowers everyone to choose end-of-life care that reflects their values, their priorities, and their beliefs. Oh, what's happening? Sorry. Okay. What we're going to cover today are what care exists currently for those who are terminally ill. I'm having a hard time with this. Hold on one second. What care options exist for those who are terminally ill? What medical aid in dying is and where it's authorized? What New York's Medical Aid in Dying Act would do? What are the benefits of a medical aid in dying law? Who supports this option in the Empire State? What role healthcare providers play, and what can you do if you support this option? So that is the run of show for this morning's presentation. It's hard to start any talk or discussion these days about death and dying without acknowledging what the New York Times reported yesterday is that we hit the 1 million mark, and we all know that the numbers are far higher than that. But this COVID pandemic, this public health emergency, will resonate across our history, really. We've never seen anything like this in this country. And I just want to acknowledge that many of us have lost loved ones. We've lost friends, valued community members, brilliant people to this pandemic. And I just wanted to take one moment to acknowledge that before continuing on to talk about a subject related to death and dying. Let's talk about what care options exist right now for people who are terminally ill. And by terminal illness, and I'll talk about this more when we speak about the definition of medical aid in dying. When I talk about terminal illness, I'm referring to an illness that is incurable and irreversible. And in some cases, particularly with regard to medical aid in dying, and sometimes with regard to hospice care, it's about how long someone is expected to live. So a prognosis of 6 months or a year, which I know is very complicated in the case of ALS. I just want to start here by talking about Atul Gawande. If you haven't read his articles in the New Yorker or the New York Times or his Twitter feed or his book, Being Mortal, I seriously encourage you to do that. I learned so much when my own father was dying 8 years ago about really listening to people and what they want. And what Gawande says in this book is that life is meaningful because it's a story, and in stories, endings matter. And that's why we're spending so much time talking about what it might look like to script or chart an end-of-life journey that matches the way we've lived our lives. So most people, when you talk to them about how they envision the end of their lives, they envision a peaceful death. They imagine maybe a soft, gentle breeze blowing through a window, white curtains flowing in the breeze, grandchildren surrounding an elderly parent or grandparent, holding their hand, telling them they love them, and passing away peacefully in their sleep or with the loving care around them. And unfortunately, that is not the reality for most people who die in this country. These are the leading causes of death in the United States. Published in JAMA, they do this report every year, and the latest statistics that we have are from 2020. And you'll see here that it's heart disease, it's cancer. Now, COVID-19 was a leading cause of death in 2020. Unintentional injuries, stroke, Alzheimer's, diabetes. These are things that many times don't allow someone to have that kind of death. Sometimes they do, but often the pain, the suffering associated with these diseases, the emergency nature of decision-making in an emergency room with some of these illnesses prevents the kind of death that we want for ourselves. And also where we die is interesting. Most people say that they want to die at home. Some don't, some don't want to leave loved ones with the image of dying at home. And so they want to be in another facility, but most Americans would like to die at home surrounded by loved ones. And you'll see here that in the past, even 20 years ago in 2000, the number of people or the percentage of people who were able to die at home was relatively low. And you'll see that number ticking up slightly. And I think it's because there is more attention now to allowing people to choose more the circumstances of their death, but still people die in hospitals, hospices, nursing homes, long-term care facilities, and other facilities, much more so than they are able to die at home. And back to this notion of, the kinds of deaths that we have and presenting in an emergency room, we know that about 2/3 of American adults have not completed an advance directive, and that they haven't let their wishes be known to their healthcare providers, to their family, to their friends about what kind of care they want and what kind of care they don't want at the end of their lives. And in fact, the treatments that most Americans would choose near the end of their lives are often different from the treatments that they actually receive as a result. So what are some of those advanced planning documents? And I could do a whole presentation on, how to do these documents, how to do these plans. But I'll just say for now that advanced directives really comprise all of these things: a living will, a healthcare proxy designation, order. In some cases, in New York, it's called a MOLST form. In other states, it's called a POLST form, or physician order for life-sustaining treatment. What are the end-of-life options that people have in New York currently? Well, if someone is given a terminal diagnosis, they have the right and the ability to seek and receive all available medical treatments and interventions, of course, limited by what health insurance companies are willing to pay and what people can afford on their own, but they certainly have the right to pursue all available medical treatments. And as some people say, fight until the end. They also have the option of discontinuing or refusing medical treatment. They have the option of seeking palliative care, including hospice services. They can also voluntarily stop eating and drinking, and this is known as VSED, and I'll talk about this a little bit more in a moment. And they have the option of receiving what's called palliative sedation, and again, I'll define that in a moment as well. Medical aid in dying is an option, as I'll talk about a little later, in a number of other states, but not currently authorized in New York. So what is palliative care? Palliative care is for people of any age, at any stage in an illness, whether that illness is curable, chronic, or life-threatening. Palliative care focuses on improving a patient's quality of life and managing pain and other distressing symptoms of a serious illness. Palliative care should be provided along with other medical treatments if the person is still seeking those treatments. And this definition comes from the American Academy of Hospice and Palliative Care. What is hospice? I think this is a very misunderstood concept. So hospice is palliative care for patients in the last year or 6 months in some cases of their lives. Hospice care can be provided in patients' homes, hospice centers, hospitals, long-term care facilities, or really wherever a patient calls home. Patient care is provided by a team of healthcare professionals, including physicians, nurses, social workers, pharmacists, chaplains, and others who listen to the patient's goals of care and align their treatments with what's important to them. They address more than just the physical needs of the patient. They also provide emotional, spiritual, and practical support, both to the patient and to their families. So turning now to VSED, or voluntarily stopping eating and drinking, this is a conscious decision to refuse food and fluids of any kind, including artificial nutrition and hydration. This option can be chosen by a decisionally capable adult who has the physical ability to eat and drink, but consciously refuses foods and drink in order to advance the time of their death. A determined and well-informed person with a significant caregiving and hospice support team can successfully choose this end-of-life option, and the United States Supreme Court has affirmed the right of mentally capable individuals to refuse medical therapies, including food and fluids at the end of their lives. So VSED is a legal option in all states. Palliative sedation, which is also known as terminal sedation, continuous deep sedation, or sedation for intractable distress of a dying patient, is the use of medications to induce decreased or absent awareness in order to relieve otherwise intractable suffering at the end of life. Although uncommon, some patients undergoing aggressive symptom control measures still have severe suffering from underlying disease or therapy-related adverse effects. And in these circumstances, the use of palliative sedation can be considered. Some people refer to palliative sedation as putting someone in a medical coma and then withholding food and fluid so the person dies in the medical coma. So turning now to the option that is not on the table for New Yorkers, and that is medical aid in dying. This is what we're talking about. Medical aid in dying would allow a mentally capable, terminally ill adult with a prognosis of 6 months or less to live to request and receive a prescription for medication that they can choose to take to bring about a peaceful death, so long as they are able to self-ingest the medication. From start to finish, medical aid in dying is about a patient and the patient's desires for their own end-of-life experience. They need to be the ones to request it, and at the end of the day, they need to be the ones to self-ingest that medication. Medical aid in dying is now authorized in 11 jurisdictions, 6 in the last 6 years, and now 1 in 5 adults lives in a state where medical aid in dying is authorized. I was privileged to lead the campaign to pass this law in New Jersey. It passed in 2019, and it's now been in effect for more than, coming on 3 years. And we'll talk about what we've seen of who uses that law in New Jersey in a moment. But let's talk about New York's Medical Aid in Dying Act. The bill was first introduced in 2015. It had bipartisan support at that time. The bills were combined. There were 3 bills at the time in 2015, and they were combined. And now we've got one bill, which I think is the strongest in the country in terms of its safeguards and its compatibility with other laws in New York. It is sponsored by Senator Diane Savino from Staten Island and Assemblymember Amy Paulin from Westchester. It passed the Assembly Health Committee in May of 2016, but for those of you familiar with the New York State Legislature, we've got a 2-year cycle, and every 2 years, the bill needs to be introduced. We're at the end of a 2-year cycle. The legislative session will end on June 2nd. The current bill number is a countdown, oddly, A4321. It's been amended, so it's A4321A and Senate Bill 6571. And the bill has more than 70 co-sponsors at this point. And the diversity of those co-sponsors is remarkable in terms of geography, from upstate, downstate, the middle of the state, Long Island, people who've been in the legislature for a very long time, newly elected members, ultra progressive members, very conservative Democrats. It really spans the gamut, even in terms of race and gender. What the bill would do is it would allow an adult who is 18 years of age or older, who has a terminal illness. And as I said earlier, that is defined in this bill as having an illness that is incurable and irreversible, and a prognosis of 6 months or less to live, which is really keyed to eligibility for hospice across the country, even though New York is a little bit more enlightened here and allows someone who has a 12-month or a year prognosis to access hospice. But for medical aid in dying, it's 6 months or less. They have to be mentally capable of making their own healthcare decisions and acting voluntarily, and they have to be able to self-ingest the medication. There are a number of safeguards, and these safeguards mirror those that exist in laws that have passed in other states. Every state that has passed a medical aid in dying law has based their law and their safeguards on Oregon's, which was passed in 1994 by voter referendum. And the most interesting thing about Oregon's death with dignity law is that it has never had to have its core safeguards amended. Usually when a state steps out and passes a new law, you have to see how it goes and then fix it along the way. And there has not been a single change to the core eligibility requirements of Oregon's death with dignity law. And many of the safeguards are the same in every other state that has passed them. But I'll highlight a few here, just because there's a lot on this slide. If either doctor has concerns about the patient's mental capacity for such a decision, they have to make a referral to a mental health professional for an assessment. And no medication can be prescribed unless and until that mental capacity is determined. Another key safeguard is that the attending physician has to inform the requesting patient about all of their end-of-life care options, including hospice and pain and symptom management. And this is really important because according to the National Hospice and Palliative Care Organization, New York ranks second to last in this country in terms of appropriate access to hospice. One of the arguments from opponents of medical aid in dying is that we need to focus on increasing access and awareness of hospice and palliative care. And I don't disagree. But one of the ways to do that is to open up conversations about what people want at the end of their lives. And this law specifically requires physicians to talk about the options of hospice and palliative care and symptom and pain management with patients who are asking for medical aid in dying. We'll talk about this a little bit later, but in states that authorize medical aid in dying, the vast majority of people are already enrolled in hospice. So this is not an either or situation. Another key safeguard is that the patient must be able to take the medication themselves. And I know that some of you may be asking questions about people with ALS having the ability to take this medication. And I will say that medical aid in dying is not a cure-all. It is not the last fix that we need to make to our broken end-of-life care system. It is just one piece of the puzzle, and not everyone is going to qualify for medical aid in dying. These safeguards are in place for two reasons. They are politically palatable, but they are also in place to ensure that we know that it's the patient's decision and the patient's decision alone to take this medication to end their lives. And lastly, another key safeguard is that when this law passes in New York, nothing changes for people who disagree. No patient has to request the medication, no physician, no healthcare provider, no pharmacist is required to participate if they disagree for moral or conscience or religious reasons with this option. So who uses medical aid in dying? Well, the fact is very few people use medical aid in dying, and looking at all of the reports from states that authorize this option given to their health departments, and we review these reports every year when they come in, about less than 0.5% of all people who die in these states actually use medical aid in dying. In New Jersey, for example, just 45 people used the law in the first 2 years since it took effect in 2019. And we'll see that number tick up a little bit when the new numbers come out in 2022. They usually come out in August. And that's what we've seen across the country. The numbers tick up slightly as more and more physicians become comfortable with this option and more people become aware of it, but then they sort of plateau and they never really reach high numbers. So in Oregon, it's less than 1% of people who die use this, but then combining these statistics, it's less than 0.5% as these other states get up to speed. And as I mentioned, more than 85% of people who obtained a prescription for medical aid in dying were actually receiving hospice care at the time that they died. Terminal cancer accounts for the vast majority of qualifying diagnoses, with neurodegenerative diseases such as ALS or Huntington's disease following as the second leading diagnosis for people who use medical aid in dying. Early on, I talked about Americans' desire to die at home, and with medical aid in dying, nearly 90% of the people who use this option were actually able to die at home. Something really interesting when you look at statistics is that more than a third, about 36% of those who received a prescription for medical aid in dying under these laws never end up using the prescription. They either lose the capacity or they just keep changing the line of what they feel like they can bear in terms of suffering. But in all of the cases that we're aware of, and we talk to so many of these dying people and their families report that once they have the prescription in hand, many people feel a sense of peace and a sense of control, where an illness may have stripped them of all control that they had over their lives. And now getting this prescription allows them to wrest some of that control back, and they die more peacefully for that reason alone. So I'm going to talk about Dr. Brian Kaysen, who used California's End-of-Life Option Act. On August 4th, 2019, Dr. Kaysen died peacefully in his bed, just like he wanted, because of his option to utilize California's End-of-Life Option Act. He was diagnosed with ALS just 2 years prior, in October of 2017, and he knew from the beginning that he wanted this option. What he said when he received the prescription is that when the time comes, I want to have the option to make my own decision. And his wife reports a peaceful passing of Dr. Kaysen. Another case I'd like to talk to you about is Paul Gustafson. And this case is really interesting to me for a number of reasons. And I think you'll see as I tell you Paul's story. Paul was initially hesitant to use medical aid in dying because he was afraid people would think he had given up, that he was a failure. He'd been a marathon runner and someone who trained himself to keep going no matter what. His wife says you get to that mile where you don't feel like you can go any farther, but you keep saying to yourself, just put one foot in front of the other. He was going to fight this and beat it because that's who Paul was. He went on newly approved medication in hopes that that could alleviate his symptoms. But with ALS, his wife says, there is no winning. His wife said, I decided to get information on medical aid in dying anyway, in case he decided to go that route. And we were told that just because you make this decision today doesn't mean that this needs to be your decision in 2 weeks. And that highlights a really important point, that at any point in the process, someone can change their mind. They talked, he and his wife, about what quality of life meant to him. And Paul said, every morning that I get to see you, he said to his wife, is my quality of life. His wife said, I knew that he didn't want to leave me. We had always spent time together. We would sit and just watch TV and hang out. We went for walks, but towards the end of Paul's life, his loss of the use of his hands and his arms meant that we couldn't hug or hold hands like we used to, and it was difficult for both of us. And I know that your seminar this week, there was one session that I saw that I couldn't attend about intimacy, and I wish that I could have attended that. I hope it is. I hope it's available afterwards. So Paul's wife said, in the end, I think he would have hung on if it weren't for the pain. Even with constant pain in his neck, I believe he would have tried to go on a little longer if it weren't for the severe abdominal pain that he developed. At this point, he was on hospice, and they tried to manage the pain, but Paul didn't do well on morphine. He couldn't tolerate a full dose. They tried at least 5 different muscle relaxants, but the pain got worse. Their daughter got married in October of 2020, and his wife went to Oregon for the wedding, and when she returned, he had deteriorated. He had to have care 24/7. His pain was at a new threshold, and he said it was absolutely time for him to go. Paul chose to pass at home on November 6th, 2020. The pandemic limited who could join, but their daughter came from Oregon, and the son was there as well. And his wife said it was a wonderful passing. It was calm. He asked that we all hold him. He told us that he loved us, and we told him that we loved him. The nurse was there to help, to make sure that he got all of the medications. And as he's telling each one of us that he loves us, he turned to the nurse and he said, "I love you too." Even in the end, he was still being him, his wife described. And then she says, there comes a point where suffering doesn't make any sense, and it's cruel. It's cruel to keep someone suffering. Keeping Paul alive would have been cruel to him, to me, to the family. It would have been the opposite of everything he believed and who he was. She says from the time he ingested the medication to death was no less than an hour. As his muscles relaxed and the medications took over, he just stopped breathing. No more pain, no more hurting. And she said, he's off running marathons somewhere else now. So that's the kind of peaceful death that medical aid in dying allows. There are other benefits of having the option of medical aid in dying. Medical aid in dying honors patients' autonomy and protects the doctors who serve them. And there has not been a single substantiated incidence of abuse or coercion in nearly 50 years of combined data across all of these states. In fact, the opposition's arguments are literally cut and pasted from the early 1990s, when no state had ever passed a medical aid in dying law, as if there had been no evidence over these past quarter of a century to show that these laws work as intended. As I mentioned before, very few people will choose to use the option, but large numbers derive the peace of mind from simply knowing that it's available. Adopting New York's medical aid in dying law will cost the state absolutely nothing, but the cost of inaction is truly high. Terminally ill people may not try that one last miracle treatment out of fear that the treatment will be too painful. Too many choose violent means to end their suffering rather than this compassionate option. Terminally ill people are being deprived of the peace of mind that comes with knowing that they can end their suffering if it becomes too great. And we know that many will die suffering without this option, while families and doctors remain powerless with no legal way to respond to their pleas for help. We also fail to gain these other benefits from medical aid in dying implementation. In states that have medical aid in dying laws, we see better use of hospice care. We see improved conversations between doctors and their patients about the kind of care that they want to receive at the end of life and what's important to them. And we see physicians seeking out and receiving better training about how to deal with conversations around end of life care. And I think if I have a moment, I'm going to play this quick video from Dr. Bob Milch. I'm just going to play this, self-explanatory.
The notion of medical aid in dying is a natural extension of the choices, options, which patients should have have legitimate claim to in end-of-life care. What patients tell us is that just knowing that the option is available is liberating, lifts a burden from their shoulders. It is in the best traditions of the profession to remain engaged with our patients, to walk with them as far down the road as we possibly can, to support them, to understand their goals, their objectives, their wishes, and then to move heaven and earth any way we can professionally to support them. Medical aid in dying fundamentally is a patient-driven component of care. With decades of experience in other places, there's never been a documented case of abuse. Legislative inaction now is punitive, and time is not an ally of the patient. We have all the data we need to reasonably bring aid in dying to fruition, certainly in New York State, where the polls have demonstrated overwhelming support from the lay public. A majority of physicians endorsing it. Legislators need not necessarily endorse it, but for goodness sake, don't prohibit it. And by not acting on it, that's exactly what you're doing. Think, legislate wisely, but by all means, legislate. Knowing that my family is supportive, now I want the option.
So you see that it's a little dated because the legislature, in fact, did return in January of 2022, and they are set to adjourn again without acting on this bill on June 2nd. And indeed, Bob Milch's family has traveled to Albany. They've spoken to the press, and what they tell us, which is very disturbing, Dr. Milch was, the founder of one of the first hospices in New York State, and he died in a tremendous amount of suffering. You'd think that someone as connected to systems of care with as much knowledge as Dr. Milch had, that would not have been his fate, but indeed it was, because there are some illnesses whose pain profile is so great that our ability to treat them in traditional hospices and with palliative care is just simply not enough, and they need this option. I'm going to do a little bit of a trigger warning here because you've seen some beautiful pictures of Dr. Milch. You didn't see pictures of him at the very end of his life when he had withered, this giant of a man, both literally and figuratively, to about 87 pounds. But I am going to share some disturbing pictures with you next. And just a trigger warning. So if you want to turn away or just be prepared for this. But I want to introduce you to Ayla Rain Eilert. She was a 24-year-old ballet dancer in New York City, aspiring artist, a yoga teacher, a beautiful young woman. And she died on April 2nd, so just over a month ago. And this was Ayla when she was diagnosed with cancer and ultimately when she died. This is from September 2021 to April 2nd, 2022. And what you might not be able to see in this photo, Ayla had tongue cancer. And by the time she was done with the incredible treatments that she underwent to continue to live, the cancer had metastasized and spread to 13 areas of her body. And I spoke with her for several weeks before she died, when she could still speak. And her last words were, "My neck hurts." And what you might be able to see a little bit in this photo is her finger here. And this is what she was doing. She was literally clawing at her neck in the weeks before she died, because she was in so much pain. She's 24 years old. And this is what she was clawing at. The cancer had developed and, came through her skin. So this was Ayla Rain. And this is what we're asking for, is for this option for people who have undescribable pain at the end of their lives. I'm just going to talk briefly about the support for this option. The lay public, as Dr. Milch says, voters in New York overwhelmingly support this option, and poll after poll after poll. The Marist poll from October 2021 shows that 59% of New Yorkers support this option and only 36 oppose it. 2/3 of Americans in surveys done by Gallup year over year, year after year after year, show that across party lines, race, age, all kinds of demographics, no matter how you slice it, about 2/3 of Americans believe that terminally ill people should have this option at the end of their lives, even if they wouldn't use it for themselves. There's a broad array of groups representing so many different sectors of our civic society that support medical aid in dying, and I've listed most of them here. This group continues to grow. And as Dr. Milch also said, support among physicians is high. When first asked about this option, 56% of doctors said, absolutely, people deserve this option at the end, with 26% opposing it. And then when they learned more about the bill, what the safeguards were, what the bill would do and what it wouldn't do, that support jumped to 67%, with only 19% of doctors opposing it here in New York. People of faith support medical aid in dying, even though leaders of some of these denominations denounce medical aid in dying as against their teachings. People who go to the services and who sit in the pews and attend the synagogues actually believe that people should have this option. This is polling that was done in November of 2021 that shows, vast majorities of people of faith supporting this option. More than half a dozen medical associations, health associations, recognize medical aid in dying as being different from suicide and support this option, and they have stopped using the term physician-assisted suicide. People living with disabilities also support this option. In the only polling that's ever been done of people living with disabilities, it shows that, and I'm sorry, the slide is a little blurry, but 2/3 of people living with a disability in New Jersey, Connecticut, and Massachusetts support medical aid in dying, basically the same measure as the general public. And it's because we share the values of autonomy, independence, and self-determination. The desire for patient autonomy at the end of life is universal, and here are some faces of people that you might recognize who support this option. And this comes at a time, this legislative debate in Albany, when the attack on bodily autonomy is becoming more real every single day. One of the things I want to close with is a quote from Archbishop Desmond Tutu, who passed about 2 years ago. And he was once opposed to medical aid in dying, but as he grew older and watched people suffer in his own life, he said that dying people should have the right to choose how and when they leave Mother Earth. And he became an outspoken proponent of medical aid in dying policies in the US and in the UK. So I just want to leave a few notes about what you can do if you support this option, and then we'll get to some questions. Maybe we should stop for questions now, actually, because I have no idea whether, those of you who are listening support this, and I can certainly talk about what you can do myself without some slides. So Helen, maybe we should check and see what questions people have.
Okay, and I just remind everybody to just put their questions in the Q&A box. So I do have a question here. How did Paul take the medication if he couldn't use his arms?
There are a number of ways that people can take the medication, but they all involve a volitional act. So you can actually load the medication into a feeding tube, but the person has to be able to press the plunger with a finger or with their mouth. You can also, if they can hold the cup or have the cup propped up and draw the medication through a straw, you can also do it that way. There is an option of rectal administration, but again, it has to be done with some kind of volitional act on the part of the patient. So there are a number of ways that it can be done, and indeed has been done, because as you saw, the second leading illness that people have who use medical aid in dying is ALS.
Okay, and tell us why it is actually taking so long for this legislation to pass.
Well, I used to be able to answer that question, and it's becoming increasingly difficult to answer that question. In the past, I would say that lawmakers were having a hard time talking about death and dying, but we've just gone through a period of 2.5 years where all we see on the front pages of the paper and on the news is our memorials and death and dying. If it's not COVID, it's police violence, it's domestic violence. It's now, not now, we've long lived with mass killings. We just lived through that in New York and Buffalo. The news is filled with death and dying. I don't think lawmakers have the excuse anymore that they can't talk about death and dying, because we talk about it all the time. Is it fear of their losing their seats? Well, we've done a study, and now we've got all these states that have passed the legislation, and no one has ever lost their seat for becoming a champion or sponsoring a bill or voting for a bill that authorizes medical aid in dying. So it's not a political risk. Is it religious? Shouldn't lawmakers legislate for all of their constituents and not just based on their own faith? I don't know. That's a question that I ask. Is it because of arguments from the disability community? Certainly, we need to listen to every aspect of civil society on this issue, and we need to make sure that we're taking into consideration the concerns of people living with disabilities. But when there is no evidence, and I know that it's difficult to wrap one's head around the absence of evidence as being evidence itself, but with the powerful opponents that these laws have, if there had been abuse or coercion, I am certain that lawmakers would have heard about it. But these arguments are the same as they were before we had any evidence. So, is it the concerns of the disability rights community? Well, if that's the case, then we're actually weighing theoretical fears versus actual harms. So every year that they don't pass the bill, people like Ayla Rain suffer while we worry about theoretical harm that has never come to pass. So I don't have a good answer anymore because it's been 7 years now, and I think that they're out of excuses, but I'm also an advocate. So that's how I would answer that question.
So we have a couple of more questions. What drugs are used for medical aid in dying?
So the drugs are not proscribed in the legislation, and that's because the pharmaceutical industry changes, medicine changes, and so this is really up to the physician. It depends on the person's body, the person's illness, what kinds of medications the patient has been on in the past. And so there are clinical guidelines that have been published. There are peer-to-peer doctor trainings that have been done. There are guidance documents from various medical institutions across the country. But generally speaking, for very many years, a drug called secobarbital or Seconal was used in large quantities. So generally, people would be prescribed 100 capsules. They would have to empty those capsules into 6 to 8 ounces of liquid, stir it, dissolve it, and drink it, a very bitter liquid. Before they would do that, they would take an anti-nauseal because the drug produces a strong gag reflex, and an anti-anxiety medication and a pro-absorption medication. So it was sort of a cocktail of drugs taken over a period of time. Again, sort of with the goal of ensuring that this was the person's decision, because at any point in that process, before you take the last medication, you could stop the process. Now the drugs are being compounded, and so many of those drugs are combined into one kind of elixir that someone takes at the end. And most people don't pick up the prescription until they're ready to use it because it can be expensive. They don't want to have it around the house. Although I will also say that the drugs that we send people home with on hospice and palliative care are paradoxically far more dangerous and susceptible to abuse than these drugs. You have to prepare someone's body for the medical aid in dying drugs, and it doesn't have a resale value. It's not a drug of abuse, and it's not something that could get in the hands of someone wrongly. And it's also never happened that anyone has accidentally or forcibly ingested this medication. So, it doesn't matter if I tell you the names of some of the drugs. You can Google that and find the clinical guidance, but it's generally a combination of certain drugs like morphine and things like that. Many people, I'll just anticipate a question that some people say, well, we do have the ability to give someone morphine. And I know people who've been given a dose of morphine that may have caused them to die, either intentionally or unintentionally. But with some of these cancers and some kinds of terminal illnesses, someone has been on morphine for so long, like Lorraine, for example, that no amount of morphine is able to relieve their pain, and certainly allow them to overdose on morphine. So that's why these medications in the combinations that they're prescribed are so important.
Thank you. We do have another question. Why is New York at the bottom in terms of access to hospice care?
It's a combination of factors, really. In part, it's because doctors in our state just are not good at talking about the option of hospice and palliative care. I know when my father was dying, I had to proactively ask for information about hospice because no one was willing to give up. My dad didn't want to give up. He was a Vietnam vet, a Marine, a strong Irish Catholic guy who believed fervently in hanging on to life for as long as possible and fighting until the end. And, my mother and I were in severe distress trying to care for him and looking for the benefit of hospice. No one wanted to say that there was nothing left that they could do. And in fact, there is never nothing you can do. Doctors need to get better at describing the benefits of hospice and leading a patient along that path. So that's part of the reason. Another part is, it could be, it's awareness, it's stigma. There are certain communities that believe that hospice is the place that you go to die. And so they don't want to admit that it's the end, and they don't want to enroll. So it's a complicated set of factors, but there are generous public benefits that allow people to receive hospice care and have that care paid for. So is cost really a barrier at this point? For some people, it may be, certainly if you're on hospice care for a long time, as some of the cancer patients that I've worked with, they've been discharged from hospice because they've been on for too long. So there's a combination of factors, but there is a package of legislation on the verge of being passed here in New York that will make the situation, I think, somewhat better. But what we know for sure is that passing medical aid in dying laws have improved conversations, have improved awareness among physicians, and really those states that have passed medical aid in dying laws are doing a whole lot better than New York is in terms of uptake for hospice and palliative care.
We have one more question. Will insurance companies deny payment if medical aid in dying is used?
So the answer is no. No one in any state that has authorized medical aid in dying no one's family has ever been denied benefits under a life insurance policy. And that's true for a couple of reasons. The law specifically, New York's law and every other law, says that medical aid in dying is not suicide. And we can dig into that a little bit if you'd like also, but medical aid in dying by law is not suicide. And also it's not considered suicide by those who use it and their families. So legally it's not suicide. And also Also, there are provisions in New York's law that specifically prohibit insurance companies from denying payment to families whose loved ones used medical aid in dying at the end of their lives. So they are statutorily prohibited from refusing. And in fact, no one has ever been denied.
Okay. So you had something else you wanted to finish up on your slides before we end? Or no?
Sure. Yeah, if folks want to know how to become more active, if this is something that you actually support, I'm going to restart this and say, what can you do? Well, your voice is really powerful. Elected officials and those seeking to represent you, we're coming up on some elections, some pretty important elections in November. Once they get the district lines straightened out and you can figure out who your candidates are, lawmakers listen to prospective constituents. And so if you're ever in a place where people are asking you for your support, you can ask them where they stand on this issue. What organizations who support this can do is they can endorse New York's Medical Aid in Dying Act. We have a sign-on letter that they can support. You could submit a memorandum of support. You can join our Alliance for Medical Aid in Dying, or you could join any of our events. We often do virtual events. We're having a demonstration in the Capitol this coming Tuesday. You can email me if you'd like to join that as well. What else? You can follow us on social media. We do far more than medical aid in dying. We talk about the whole range of end-of-life care and improving end-of-life care. And you can follow us on Twitter, on YouTube, on Facebook, and on Instagram. If you follow us on Facebook or Instagram, you can like us, you can share our posts. This is a post about Farah Souffrant Forrest, who is an assemblywoman and a nurse, and she is a strong supporter of medical aid in dying. And this is a photo on the right of Father Luis Barrios, who is a strong supporter of New York's Medical Aid in Dying Act. And so you can retweet posts that you like, or you can like or share on Facebook. You can also express your opinion in letters to the editor or opinion pieces. These are two women that I worked with in Buffalo, New York, Jennifer Milich and Deborah Stern. They authored a joint opinion piece in the Buffalo News. Deborah Stern is still with us, and sadly, Jennifer died in March, and her death was among the most horrible I've ever witnessed myself, and her family have now all become advocates for medical aid in dying. And just a note, I just want to remember one of our strongest advocates, Faye Ho Yin, who died during the pandemic. She said, I support medical aid in dying because I think it will give so many terminally ill patients some sense of control when pain becomes unbearable. And what's heartbreaking about Faye's story is that she and her daughter spent the last weeks and months of her life trying to figure out how to avoid the pain and suffering and to meet with their lawmakers. And Faye was never able to get a meeting with her senator while she was dying. And her daughter, Monona, who she lived with in Brooklyn, encountered that state senator at a farmer's market a couple of weeks ago and spent an hour with him talking about the horror that was her mother's death. And her senator signed on to the bill about 2 weeks ago. So it makes a difference when people share their experiences. And here's me. I just want to leave you with how to get in touch with me if you have any further questions that you might not have wanted to ask here on this webinar, or if you'd like to learn more about our campaign or join our efforts. So Helen, are there any other questions, or should we?
Actually, can you just take your screen down? Yes, we actually have just one more question, and we have just about 2 or 3 minutes more.
Okay.
And that is, can a New York resident travel to New Jersey or Vermont to use medical aid in dying?
Well, that is an interesting question. Our organization brought a lawsuit that challenged Oregon's residency restrictions because there was a doctor in a neighboring state who was caring for patients on both sides of the border, and the court Well, the court didn't have to decide because the other side admitted that in fact there was a constitutional issue and that they would amend the residency restriction. And so there is a question about whether these restrictions are constitutional. The fact is, at this very moment, it is you can move to New Jersey. You have to become a resident, and there are some things that you need to do. You can get a voter registration card or a driver's license. You need to prove that you reside in New Jersey, but it is very burdensome at the end of life to do that. Not only are you leaving your home and your support system, you may be too weak to travel, but it's very difficult to establish a care team at that point in an illness. Some people do it, not very many. So it is possible, but it is very difficult to do. And what I think is so stark to me is this issue of borders. Ayla Rain Eilert was receiving care at a hospital that served patients from both New York and New Jersey. People from New Jersey would go to that hospital and go home with the peace of mind of knowing that they had access to this care. And Ayla would return to her apartment in Manhattan knowing that she didn't. And she begged every one of her healthcare providers for this option, and they all had to say that it wasn't available here. So I said a little bit more than can you move to New Jersey, but yeah.
Wow. Thank you so much, Corinne, for all of your presentation. It was wonderful. I learned some new things also. And I feel like this is such a good opportunity for those who are on and who is listening to this, that it just opens the door for communication with their loved ones and their families to see what they really want. So I'd like more information. I think that if you could send more information to us about being an advocate, I think if you sent it to our office, that would be terrific. And I think we're about finished. And thank you so much. And thank you all for participating. And don't forget that the next breakout session starts at 10:30. And it is with breathing, a sigh of relief. Thank you all for coming.
Thank you.
All right. Take care.
Bye-bye.